Good afternoon, everyone. I'd like to welcome you to a webinar today presented by HealthCareCAN in collaboration with the Canadian Frailty Network. The topic of this webinar is the policy and economic considerations for frailty screening in the Canadian healthcare system. We are very pleased that so many of you are able to join us today. My name is Jennifer Kitts, and I'm the Director of Policy and Strategy at HealthCareCAN. HealthCareCAN, in collaboration with the Canadian Frailty Network, is conducting a study of the policy and economic considerations for frailty screening in the Canadian healthcare system. Our study is guided by an expert steering committee, which includes representatives from the Canadian Nurses Association, the Canadian Medical Association, the Canadian Hospice Palliative Care Association, and the Canadian Pharmacists Association. Our research is based on interviews with key informants as well as literature review. Today we will be discussing preliminary results from key informant interviews, and we'd like to be able to get your input into our study today. Before we get started, I just want to point out to you that if you're experiencing any technical issues during the webinar, please contact the number provided in the Q&A pod. You can also contact the number at the bottom of the screen, Katie Ellis from HealthCareCAN. I'd like to walk you through some of the features of our technology today. First, to prevent background noise, please mute your lines by clicking *6 or by using your phone's mute function. As I mentioned earlier, because the webinar is recorded, we will mute all lines and we'll be using lecture mode so that there's no distracting background noise. We will be getting your feedback and answering your questions at the end of the presentation. If you have a question or feedback, please enter it into the Q&A pod on the right side of the screen at any time during the presentation. So if you have a question when someone's speaking, feel free to write it in that Q&A area, and we will answer it at the end of the presentation. And as I mentioned earlier, the webinar is being recorded. We also have some questions that we'd like you to consider. For example, given your experiences in this area, do we have the issues right? As I mentioned, we're sharing preliminary results today, so we'd like to know if we have the issues right. Have we missed anything? And where should the leadership come from on this issue? I'd appreciate it if you could keep these questions in mind, and if you have input at the end of the webinar, we'd like to hear from you. We have 3 presenters today. First, Dr. John Muscadera, the Canadian Frailty Network Scientific Director and CEO, will be providing some background on the Canadian Frailty Network and this research project. Dr. Muscadera is an intensivist at the Kingston General Hospital, and he's also Professor of Critical Care Medicine in the Faculty of Health Sciences at Queen's University. Second, Mr. Bill Thal is President and CEO of HealthCareCAN. He will be describing why this project is important to HealthCareCAN. HealthCareCAN is the national voice of Canada's hospitals and healthcare organizations. Mr. Thal is an economist by training, and he will also speak in particular to some of the economic considerations. Finally, Ms. Kelly Grimes will present on key findings from the key informant interviews. Ms. Grimes is the Health Policy and Research Consultant for HealthCareCAN. She's also the Executive Director of CHLNet. Now over to our first speaker, Dr. John Muscadera, who is CEO and Scientific Director of the Canadian Frailty Network. John?
Thank you very much, and it's a pleasure to be here on this webinar today, and thank you to all the attendees for taking the time out of your schedules to come online with us. This is an important area Frailty Network, and we appreciate your participation. So just a couple quick words about the Canadian Frailty Network. We're a national centers of excellence funded national not-for-profit network, and our focus is on improving the care for the frail elderly within the Canadian healthcare system. We create knowledge through original research, we mobilize knowledge into policy and practice, and we train the next generation of scientists, practitioners, and knowledge users. Our network has grown rapidly, and at the present time we encompass 42 universities and teaching hospitals across Canada, 400 researchers, 130 health agency and advocacy groups, and we have 20 national and international corporations who are partnering with us, and we are in regular contact with 3,200 knowledge youth across Canada, which are span the spectrum from clinicians to decision makers. And an important part of knowledge mobilization for our network is building awareness of why frailty matters and the healthcare system. And towards that end, we've engaged with clinicians, but also an important part of it is in engaging with decision makers and policy makers. And we've had two national forums, one that was held last year in June, and our next one is coming up in May of this year. And these forums are the ability to get decision makers, clinicians, or citizens together to discuss frailty and to discuss the implications for frailty screening within the Canadian healthcare system. The first forum, which was held in 2015, led to a paper which has been accepted for publication, should widely shortly, and that was entitled "Screening for Frailty in the Canadian Healthcare System: A Time for Action," and that broadly outlines the implications of frailty screening. And following up on that, we commissioned 5 working groups which look at the various aspects of frailty screening or the identification of frailty within the Canadian healthcare system. The 5 groups are outlined on this slide, but and the reason why we're on this webinar today to look at the policy and economic considerations, which has been developed through our grateful collaboration with HealthCare Canada, and that's the main item for discussion today. All these 5 papers will be published in a supplement in the next while.
Hello, this is Bill Thal. Welcome everybody on behalf of HealthCareCAN. Bienvenue à tous à ce webinaire. It's a delight for me on behalf of HealthCareCAN to add our thanks to John and his group at CFN. Is a delightful partnership so far, and we're looking forward to continuing to work with John and CFN. I guess it's because I'm a recovering public servant of many years and an economist by training that I've been asked to kind of kick off the policy and the economic, set the policy and the economic context for the webinar. So I'll start by saying that frailty and frailty screening were identified early on by HealthCareCAN after its inception just 2 years ago as one of 3 areas where we really wanted to zero in on vulnerable groups. The other 2, by the way, are children and mental health, and we also got initiatives in both of those areas. One of the ways that we gave expression to this rising level of interest and concern was to host the first Great Canadian Healthcare Debate in Prince Edward Island last June. And I wanted to flag for you the fact that frailty and frailty assessment screening was identified as one of the top 10 policy issues by healthcare leaders across the country for a number of reasons that I'll get into a bit later. We also polled the Canadian public in terms of, with our friends at Ipsos Reid, and we found that Canadians were overall worried about a couple of things, actually. One is they were quite worried about falling through the cracks. As one of the interviewees or one of the reporters reported out, people are worried about who's going to find my marbles when I lose them. In other words, very concrete concerns. 70% of Canadians were worried about either themselves falling through the cracks or their loved ones as they get into their frail or near frail parts of their lives. And I think it's 90% of the system needs to do a better job of identifying the needs of frail seniors and providing them and their caregivers with more support. What's not in your slides there, though, I would flag, is that about the same number of Canadians, 70%, also were worried about Canada's healthcare system falling behind that of other healthcare systems. And again, one of those areas where we need to learn from the rest of the world and do a better job relative to the rest of the world is in the whole area of frailty and frailty assessment screening. So moving then to the policy context, this could actually be a whole webinar on itself. So we're in an interesting time as we move from a system that was built for acute care, episodic care, into one that needs to respond to the increased chronic care needs of Canadians and the realities of more and more comorbidities, including, for example, the close correlation between dementia, for example, and frailty. CEOs across the country are increasingly concerned about a number that's at 14 or 15% and continues to not go down in terms of the appropriate placement of people. There's a lot of patients who are inappropriately in acute care facilities or long-term beds in long-term acute care facilities, and we need to more appropriately place them. There's increased demands on caregivers as we see the so-called sandwich generation taking care of both kids and their parents. There's probably nobody on the line that hasn't been affected very directly by that. And there's an increasing dependency ratio. So it was just recently reported that we have more people over the age of 65 now than we have people under the age of 15. So serious issues there around sustainability financially. Opportunities, well, there are many of them, but one of them is that we have a new government in town here in Ottawa. They care about health and healthcare deeply, and in the minister's mandate letter, for those of you who had a chance to review it, the whole area of home care, chronic care, and so forth has been given one of the top four sort of kind of tops the top four lists for the minister. There's also the early days of negotiating the new health accord, and again, we're pleased with the degree to which issues around seniors and frailty are gaining attention. So next, economically, overall, we've got an economy that's growing slowly, more slowly than anybody would like, and at least as importantly, unevenly. We've got large and growing deficits across Canada, and here in Ottawa, with the recent budget allowed for up to $40 billion annual deficit. Overall, aging continues to be a cost driver. Only about, actually, it should be 1%, not $1. Apologies for that. But again, it's not borne equally. We know that the percentage of the population over the age of 65 and the old is not evenly distributed across the country. So it's clearly more of an issue in Atlantic Canada and British Columbia than it is in places like Alberta. In terms of, again, as we look at the spread and the cost implications of this, I mean, the average Canadian costs accounts for a healthcare cost of about $2,600 per year, according to recent KII data. Over the age of 65 is $11,500, and as we get into the old, those closest to frailty, it's closer to $20,000 a year. In terms of opportunities, as an economist, I was taught very early on, never let a good crisis go to waste. So this is an opportunity for us to really look hard and long at the most cost-effective way of meeting these needs. And one of my mentors, Dr. Malcolm Taylor from York University, once said, we've been much more successful during times of fiscal famine rather than fiscal feast. You can't buy your way out of change. In fact, times like this where we really have to look hard and long at how we're spending our money lead to the most permanent changes in our health and healthcare system. It's not an accident, for example, that our Medicare program and before that our hospital insurance program were actually on the heels of some of the biggest recessions we've had in this country. So with those as kind of, the sort of setting the stage, one area where we clearly need to do a better job is in the area of specifically frailty assessment screening. We've got over 20 tools across the country that we need to make sense out of. And this is kind of what helped us to reach out and partner with the Canadian Frailty Network to move the yardsticks forward and to ask the following research question. Just before we ask Kelly Grimes to kind of take us from here, so here's the policy question that we put to Kelly and the team. What are the policy and economic considerations, both for Canada and internationally, to be taken into account around frailty screening that will benefit patients, families, and or the wider health system. So over to you, Kelly.
Thanks, Bill. Thank you all for having me today. It's been a real pleasure to be part of this project with HealthCareCAN and the Canadian Frailty Network. I just wanted to give you a brief overview of the methodology that we use. So as Jennifer mentioned, we had an advisory committee in place who guided us through the research question and what the protocol should be. We did undertake a small review, I should say quite small, but it did give us some ideas about where we needed to focus our efforts. As well, the key informant interviews provided some insight as well. And then this last piece, the webinar, we really believe our methodology is iterative going forward. So we will be taking your comments and input from today and moving it into final recommendations coming from the report. And as John mentioned, that should happen in May sometime. So going forward, what are some of the preliminary insights from these key informant interviews? So we did do 16 interviews across the country. It was a real cross-section of patients and providers, policymakers, and researchers. Each interview was 45 minutes in length, and it really brought to light for us many of the policy and economic challenges and opportunities around frailty screening. It was so interesting talking to people because almost every one of the interviewees had some tale about how frailty had touched them and their families, including myself, I'd have to say. So it really also cemented for us the importance of some of these interventions that are already happening across the country around frailty. Places like in BC around CARES, in Ontario, Arctic's Move On, the A strategy at Mount Sinai, and PATH in Nova Scotia. So before I go into some of the specifics about what we heard, I just want to give you a quick background of some of the fundamentals of policy instruments. So really there are about 6 or 7 main types of policy instruments that are used to leverage up any change that we want to make in the health system. So the first one is financing, how revenues are raised, like through taxation is the main one, obviously. Funding is how healthcare organizations, providers are paid to carry out their work. The next one is legislation and regulation, partnerships and networks, technology, and lastly, public awareness campaigns. There isn't a slide on this, but I just want to give you some sense of when we were talking to people, these were the instruments that we were mulling over as we were going forward. It really is important to remember that the objectives of any policy instrument are multifold, but government action is often dictated by what they did in past practice. So it's important to look across the country by province and territory and federally about, what did they do around some of these issues in the past, and then think about that as we move forward. Again, it's always a function of the political climate of the time. So on to the slide about the top 7. These are the top 7 issues that we heard from the key informant interviews. So really compelling results that people got us thinking about as we were going through. So these were the top 7, but there were actually a few other that came to light, but we won't talk about them here given how much time we have. There were things around the supply of health providers, education, and training. But these were the top ones we heard. So the first one is the Federated Health System. The second was financing funding models. The third was regulation and legislation. Then technology. Then interdisciplinary collaborative care. Patient-centered care and service. And then the last one was health promotion and disease prevention. I'll be going through each one of these, some of the issues for each one or challenges, and as well some of the key insights that we heard going forward. So the very first one, I should say, was around Canada's Federated Health System. Everyone talks about we actually have 14 different systems occurring in Canada. There's the 10 provinces, 3 territories, plus we have a system at the federal level. This means really that achieving consensus on a pan-Canadian basis is a very, very complicated process, and the keys reinforce that for us. In fact, Greg Marshallton, who Bill and I have worked with over the years, says that across the world, Canada is the most decentralized health system in the world. Again, making policy and economic considerations very, very complex and multidimensional. As we all know, compared to international jurisdictions, Canada continues to slide down the league tables. We've heard it, we've seen it many times, but just we got to keep this in the front of our minds. We are 10 out of 11 countries on key indicators according to the Commonwealth Fund. We are only ahead of the U.S. on some of these things, and we really need to be doing more internationally, and I think this is one area where we could be doing much more. As Bill highlighted, with the federal re-engagement, we have a new government in place, and in 2017 and 2018, the Canadian Health Transfer Payment actually expires. So this is when the federal government actually transfers money to the provinces and territories to support health care itself. So we are expiring. So again, there are some pieces, and I'll talk about these later that we can consider as part of this conversation. And the last big piece is that a new health accord is being promised by the federal government for 2017. Bill mentioned the new federal minister's mandate letter, which is highlighting the need for better home services and palliative care, but as well more work on digital health technology. And frailty screening really fits in well into these areas. Even Naylor, in his seminal report, probably many of which you have read around unleashing innovation, talks about that the time is right for some of these conversations and innovation. And as we talk to the keys across the country, there are pockets of innovation occurring, and we need to share these more broadly. So, flipping the slide, some of the key insights that we heard. And again, I should actually remember it. Key is key, inform, and introduce. So as you're seeing those through the slides, that is exactly what it means there. So the first big piece is that frailty is a multifaceted, multidimensional concept. The Keys really believe that we need to complete the dialogue on a common leadership language, and that the discussion needs to be not just on the frail elderly, which was the scope of this project, but even broader for children, youth, all through all stages of life. The second big piece we heard from the key informant interviews was the need to link health and social services more. We need more of a systematic approach across public policies at all levels of the health system, from macro to meso to micro. Health and social services, as most of you know, within governments are separate. Sometimes they're not, though. And a couple of the keys suggested that we needed to look at models like in the UK about joined-up approaches. They can provide some interesting data to look at. And once the homework is complete on whatever desired approach we want to do around these issues, based on available evidence, an ongoing pan-Canadian advocacy strategy is needed based on government mandates. One, actually, Keys talked about that we really need to be promoting frailty screening as a level 1 policy across provinces, like, for example, advanced care planning in Alberta is. It crosses settings. It's just not one ministry, and it is embedded in all the work that they do. And lastly, and very importantly, we need to really ensure actions shift reform from population aging to chronic disease management. As Bill indicated earlier, age is not a huge cost driver for the health system, but chronic disease is. So the second big piece was around funding and financing models. Some of the big considerations of this piece as we go forward is the public-private split. So 70% of health funding is still from public sources, mainly taxation, and this has not really changed much over the years. But the private pieces also have some interesting ideas that we could start to explore a little bit more. It still encompasses 30% of the public spending, but things like employee health insurance plans are something that we can be considering, and those did come up to light during the interviews. There are also tax and loan policies that could be considered to support frailty, although perhaps not screening always per se, but ideas such as caregiver tax credits, physical activity tax credits, reverse mortgages, home capital upgrades. Many of these were discussed and brought to light when we were talking with people. Another interesting idea which was raised was around pre-funding services for seniors through mechanisms like publicly administered long-term care insurance or personal health savings accounts. Some other countries like Japan are exploring some of these initiatives, and it may be something we want to do here in Canada. As always, remuneration of health providers to carry out frailty screening is a big area to address. 72% of physicians are still under fee-for-service mechanisms, and so we need to be thinking about how to remunerate providers appropriately to begin to do frailty screening across the country. And the last big point around this is that there are large variations in funding models across the country. We have family health teams in Ontario, PCNs in Alberta, but in BC I hadn't heard of their divisions of family practice model. And they're really actually doing some neat things around moving to giving more flexibility to reimburse for health for interventions that are beneficial to the wider population, things like frailty screening. And this was a new area for me. I hadn't heard much, and so I think it is something we need to consider moving forward. So the key insights coming out from the interviews were maybe that we need to be thinking about advocating that age be a determining factor in transfer payments to the provinces and territories, as the elderly often live with multiple chronic diseases in the first place. The other thing we heard was encourage further tax credits for frailty screening and pre-funding health services for seniors, such as tax-free savings accounts. We did hear this suggestion several times around adjusting the fee-for-service code to include pre-frail assessment of pre-frail seniors annually as a preventative screening practice, and again, that might be something that is explored further. And then the last one was encouraging team-based funding models like the FITs and PCNs embrace frailty as a preventative screening tool and remunerate it appropriately going forward. So the third area in terms of policy instruments was regulation and legislation. So three big things around this. First, health professional regulation obviously varies across the country by province and territories and ensures the accountability of most but not all health professionals. In fact, professions like physician assistants aren't always under legislation and regulation in some provinces. For example, Manitoba, they are, but in Ontario, they may not be. So through legislation, we are seeing that there is a widening scopes of practice. Pharmacists are now can provide flu shots in drugstores, those kinds of things. And the third point around regulation and legislation that we heard was around the standards of care piece. Legislation to govern health delivery organizations like hospitals and long-term care centers varies across the country. In fact, in BC, and I didn't realize this as well, that the long-term care homes fall under the contracted care the contracted care homes fall within the Community Care and Assisted Living Act, whereas others fall under the Health Authorities Act. So as a result, the standards of care may be different in each setting. So a Hospital Licensing Act is less stringent about having medication reviews each month in residential homes, those kinds of things. So we need to be exploring that a little bit further going on. So coming out of this discussion, there was two big things that came from the key informant interviews. The first is to encourage frailty screening within widening scopes of practice of other provider groups, especially nurse practitioners, physician assistants, those kinds of things, because they do take time to actually conduct the frailty screening themselves. The second piece we heard was promote frailty screening as a standard of care in legislation and standards. And in fact, I worked for Accreditation Canada for many years, and within their standards as well, there is a real opportunity to have this as part of the standards themselves and ensure consistency across the country. So the fourth policy and economic consideration was around technology. And as you know, Canada Health InfoWay reports that electronic health record data is now available for 91% of Canadians across Canada, but we still lag behind many other jurisdictions. Canada Health InfoWay has actually launched a multi-jurisdictional effort for an e-prescribing solution for a safer drug use, especially among seniors, and we all know that over-prescribing can feed into this hugely, and de-prescribing strategies are on the rise as well among pharmacists. And many keys noted a huge piece was the need to embed frailty screening tools in EMRs to generate population data. We need to build the evidence base moving forward. So often, many of the keys talked about the work being done by InterRI, which is a nonprofit research network comprised of 60 health researchers in 30 countries. 9 provinces have mandated one or more of these instruments. And I should point out that this piece is the purview of another paper, but it did come to light as we were talking to people across the country. So obviously, coming out of this, some of the big pieces from the key informants on the technology were encouraging the computerization of frailty screening tools, promote frailty screening tools, be integrated with EMRs, and support data aggregation across systems and settings. So we can build a real picture of our population, what their needs are, and how we can build frailty into it. The 5th piece, let me flip this, is around interdisciplinary and collaborative care. So the first point here is around labor demand growth. The Conference Board of Canada forecast predicts that labor demand growth for the continuing care sector will far exceed labor force growth more generally. So we heard from some of the keys that they are adjusting staff mixes already in long-term care homes across provinces to accommodate these sorts of issues. There really has been an increase in team-based care occurring across the country, especially in primary care, and this does represent an opportunity for embedding frailty screening as a preventative screening tool going forward. One key actually made me laugh because they said primary health care is often burdened with being the solution to world peace, and it is true. They can't do everything, but again, this is a great place to begin doing these sorts of things. And that frailty screening must be linked to care pathways, especially in the transitions of care. So coming out of this conversation about collaborative care, we really heard that a one-size-fits-all approach is difficult to achieve for frailty screening. The best tools to be used in which settings can be confusing, but really it's required. In fact, several of the keys talked about that we need our right people, right tool, right setting, or right time approach based on evidence. And again, that is the purview of another paper, but the keys did support that. As Bill mentioned, there are 20 different tools, but the keys didn't really come up with a consensus about whether we needed them or not. And in fact, they did suggest that we needed some overall and simpler, more generic tool that lay people and families could actually apply themselves to use to see how their family members are actually doing. The second big piece we heard was we need a consensus on who should be screened for frailty. Is it a combination of age? Is it health condition? Is it psychosocial disorder? Is it the high users of the health system? Is it someone who has a change in living situation? And there's piles of other criteria. In fact, I saw one of the questions was around nutrition. We didn't have any consensus from the interviewees when we talked to them. So again, there will need to be much more discussion on this piece. And the third one was we need to advocate to colleges and universities for more frailty knowledge sharing at both the undergraduate and the graduate levels. You know, training and education needs to be more collaborative among provider groups, but also topic areas like gerontology, palliative care, those sorts of things. And it's not going for, oh, there we go. So the other big area that we talked about with the key informant interviews was around patient-centered service. Many keys noted that the focus of healthcare has really been on the business model of delivery, especially around improved process efficiencies like lean, an emphasis on utilization outcomes like length of stay, ALC days, patient flow, those kinds of things. We need to do that, but we need to shift the conversation to a more population-based and person-centered care and service. And in fact, as we're looking across the country, many of the provinces are demanding this transformation and are moving forward on this agenda. So the other thing we also heard is that we need to strengthen integration, especially with home and community care. I know we always hear about the transitions of care where the cracks happen, where the cracks and where the patients fall through, and we need to really focus on this. And as well, the goals of care and what the patient desires, and often what the patient's desired is to be at home longer, we really need to make sure that these voices are heard in upfront policy. So some of the key insights then coming forward, not surprisingly, are that patient and family be at the center of any policy action required around frailty, and that we integrate the collective voice in frailty screening work. And there's amazing patient partnerships in place across the country, like Impact BC's Patient Voices Network and Patients Canada. And what we heard from the interviews is that we need to build this in going forward. The last one is, but never least, is around health promotion and prevention. We've been hearing since the 1970s around the Wallom report around Canada's health system needs to really focus on this area. And really, we all know in our hearts that this is the right thing to do to have a healthier population. But again, it often falls down to health system priority actions. Obesity rates are still on the rise. But there have been some successful and not so successful screening tools and approaches for prevention that have worked in Canadian system, like Framingham for heart disease, mammograms for breast cancer detection, those kinds of initiatives. Frailty screening could be built in as one of these ideas. So overall, what we heard was that we need to be promoting earlier detection and screening for frailty as a standard of practice in primary and community care sectors especially, but also in the transitions of care, and that there really is a need to integrate frailty into overall healthy aging strategies that are being developed across the country. So again, this is my last slide. The key takeaways really from talking to people across the country is that everyone's really touched by the challenges of frailty. There seems to be a burning platform for action, especially given the economic challenges that face our health system right now, but also with the new federal government's re-engagement. It seems like the time is right to really create that perfect storm to scale up frailty screening as a policy issue across our federated health system. So that's really it from me. And Jennifer, I guess I turn it over to you.
Thank you very much, Kelly. That was terrific. Very, very informative presentation. We now have time for questions, and we've already received several excellent questions. I want to remind everyone that if they have a question, to please enter it in the Q&A pod, which is on the right-hand lower corner on the screen. And we'll be taking questions from everyone. Before I get into questions, I want to thank all of our speakers. So first, I want to thank Dr. Muscadera for providing background on the Frailty Network and about this project. Thank you, John. And to Bill Thal, the President and CEO of HealthCareCAN, the national voice of Canada's hospitals and healthcare organizations, for setting the stage for us before Kelly's presentation on why this is such an important issue to HealthCareCAN and providing an excellent overview on the policy and economic considerations. And last but not least, Kelly, thanks so much for providing an excellent overview of the key findings from your key informant interviews. I think it was an excellent overview of what you heard. And of course, many of our people who were interviewed are listening today. And for those of you who participated in key informant interviews, I want to thank you for taking part in this study. So in terms of questions, Kelly, the first question I'm going to turn to you. We received a question saying, when you say incorporated frailty screening in our care practice, do you mean hospital, emergency department, or primary care? So someone's asking if you're speaking about do you mean hospital, emergency department, or primary care?
I mean all of it, I would say, and John could probably address this a bit more. I mean, really, it has to go across settings from primary care to to long-term care. It needs to be embedded in all settings, and that was one of the points around. There are 20 tools across the country, but perhaps each tool needs to be modified based on each setting. But I do think that primary care presents a real opportunity for embedding this as a preventative screening practice up front, but also the transitions of care, moving from a hospital to a long-term care home. There's a huge opportunity, and there are practices occurring across the country where like at Mount Sinai, where they actually are doing this already, and we need to scale up innovation, as Naylor says, and move those further.
Terrific, Kelly. John, do you have anything to add?
Sure. So, good comments. I think that when the Canadian Frailty Network started as a TVN or Tech Value Net, we were focused predominantly on acute care, but the strong message that we obtained in our discussions across the country was that unless there was a focus across all settings of care, we wouldn't be able to achieve to make significant improvement. So when we talk about the identification of frailty, it should be in all settings of care, and ideally it would be a transportable process such that there may be different nuances in different settings, but it should be in all settings of care, and particularly as was said before, around transitions of care, where we seem to have a lot of issues, especially with people who have very complex medical needs. I'll stop there.
Thanks so much, John. We did receive a question about whether we'll be sharing the slides, and absolutely, following this webinar, we will be sharing the PowerPoint and a recording. We will also be posting it to our website, so just so everyone is aware of that. We received a question, and John, I'm going to be turning this over to you, asking specifically about specific screening tools. So just to let everyone know, as John mentioned at the beginning, there are several papers that are happening, and one is specifically looking at frailty screening tools. And we did receive several questions about specific tools, but I'd like to, this question asks, or the person says that she's used the ISAR tool developed at McGill, and she's familiar with Interact, but she's sure there are others. So I don't think today we're going to get into detailed tools, but I'll turn it over to you, John, if you just want to speak to that. She wants to learn more about specific tools.
Sure. There are multiple tools that have been described, and a recent review described, I think, 21 validated tools that can be used. I think and so when you look at the multiplicity of tools that are available, I think from a Canadian perspective, and the reason for having these type of conversations is to arrive at a consensus on what can be embedded in the Canadian system, particularly as we move forward to electronic medical records, what can be easily implemented there. Some are fairly complex. Some are quite simple. I think to go forward, and then you look at whether you're screening or you're assessing for severity, which can be quite different, and different areas may have different nuances. So as part of our forum going forward in May, that's going to be a big topic of discussions as to how we move this forward. Certainly Interact is used widely across Canada, and there are ways to obtain frailty screening from that, so we're going to be looking at that, but we need to have the conversation, arrive at a consensus, and make a decision as to what we promote in what different area, and then also address some of the other issues that were raised as to which populations, what the criteria you use, and all things going forward. But I think we're at there's a lot of Canadian innovation that's been in this area. So for example, Ken Rockwood's group with clinical frailty scale, with the frailty index, Darryl Lawson's group out of Edmonton, the Edmonton frailty scale. So these are all out there. They're all actively engaged in our network, and I think our goal is to arrive at a consensus as to how we do this at an individual level, and that's going to be the focus of one of the other papers that's going to be coming out of the May forum.
Thanks very much, John. Our next question is I'm going to direct to Bill Saul. So the question is, there's a real need to build the evidence on the impacts of frailty on the economy. What are some of the key mechanisms to do this?
Well, first off, let me agree with the premise of the question. I think there is a real need, based on the work we've done with Kelly and so forth, to document the impact of frailty on the overall economy. I've not seen any impact analysis done specifically, but in terms of the mechanisms, I guess there are two ideas there. One is technically you'd want to get into costs and benefits of frailty, near frail elderly. That would involve not just the direct costs that are being tracked by organizations like the Canadian Institute of Health Information, but also get at indirect costs. Example being, the time that people have to take off work, right, to take care of their loved ones. The cost of expanded compassionate care tax credit is another example of the kinds of things that you'd want to take into account in terms of an overall cost-benefit analysis. The second kind of technical response would be factorial analysis, where you try to factor out these comorbidities. Obesity has been mentioned. I mentioned earlier on dementia. John could comment further on some of the other comorbidities around heart disease and so forth. So we'd want to make sure that we don't double count on the one hand, but we don't undercount on the other. Last point would be, in my experience, you'd reach out to other organizations like the C.D. Howe Institute or maybe the Conference Board of Canada or the Institute on Research and Public Policy. It's too bad we don't have a Health Council of Canada still around, because that's who I'd be approaching right now to try and engage with us in doing such a study. But clearly, such a study should be done, and maybe that's one of the things, John, we can carry forward in presenting this report to the May forum.
Thanks so much, Bill. John, anything to add to Bill's comments on that question?
So I totally agree with everything that Bill mentioned. I think that this is a very important area. Some of this data will be easier to obtain than others, such as the indirect costs, which probably are higher, and so I think this will be some of the work that's done. So and I think sort of implementing recognizing frailty earlier or recognizing frailty better, I think will allow us to actually get these impacts much easier going forward. In some areas, we know that the vast majority, so for example, long-term care, we know that the vast majority of people in long-term care, approaching 100%, are frail, so that's we can get those numbers. We know that the majority of people in acute elderly people hospitalized are frail. So that we can get some sense of that. It becomes less easy in primary care settings, but I would be supportive of doing further work on this area to characterize it better, and it's just to highlight the importance of this issue on the Canadian healthcare system.
Thank you very much. The next question is going to be for you, Kelly. The question is the following. What would be some of your key recommendations or low-hanging fruit to ensure that the health system embraces frailty screening as a successful screening practice?
I think actually that many of the low-hanging fruit are things that John and Bill already referred to. So we really need consensus on what we mean by frailty, who should be screened for it, what tools should be used in what setting. And I think that once we have that, advocacy, we need an advocacy strategy that's multi-pronged, goes across the country, talks to various provinces, and looks at how we can actually embed frailty screening in policy endeavors going forward. I think both Bill and John also talked about the important piece of building frailty screening into existing EMRs, etc. So it is computerized, so we can begin to generate evidence out of population health data. And I think that the last big thing I would say was that we should really encourage, team-based funding models, especially in primary care, that they embrace frailty as a preventative screening tool in their practices, because it really is there that we can really assess pre-frail among the elderly in place. So those would be my big things moving forward. And probably Bill and John have others to add to that.
Yeah, John, do you have anything to add in terms of low-hanging fruit?
I think those comments were right on. I think it's not so much that the low-hanging fruit, but I think we're primed for a change in the way we view health care for the elder. For the elderly. So there's been a lot of talk about senior strategy and healthy aging, but I think we need to sort of be a bit of a course correction to look at the most vulnerable of those that are aging, those that are approaching late life, and I think we're poised for that. So in a sense, that's a bit of a low-hanging fruit, that the conditions are ripe for change.
So I'll just add very briefly, they're not low-hanging fruit, but I think they're critical to moving forward. One is to get our minds around and get a consensus around what do we mean by frailty, an operational definition of frailty. We're still struggling with that, number one. Number two, as an economist, I would just simply say Maoism gone wild in terms of frailty assessment screening tools is not good for either those who are the receiving end of those tools, nor those that are expected to pay for all of those tools. So I'd expect we need to move very rapidly towards some consensus guidelines about which tool for which setting, and have sort of the best tools applying in the system.
Thanks very much to all of you. I'll just state a comment from one of our participants. She's suggesting that there's a need for education and competency training of all stakeholders regarding variations in patient populations. So we will thank you for that comment, and we will ensure that that's considered. The next question would probably be to you, Kelly and John, and it's the following. So given that aging is only a modest cost driver, Bill spoke to this, 0.9% per year, how do we shift reform from population aging to chronic disease management? So Kelly, I'll ask you to speak first to that, and then I'll turn it over to John afterwards.
I feel like I'm repeating again, but really it's building the evidence. So we are hearing that aging is only a modest cost driver, but we are hearing that the elderly often have multiple comorbidities and have cognitive impairment, all those kinds of things. And so we need to, especially with the Health Accord and federal re-engagement, I think that there's a real opportunity to embed chronic disease management and frailty, link them together as part of some of those strategy, as an advocacy strategy going forward. I think that's maybe where we'll get a lot of bang for the buck, and we keep needing to bring some of those stats to the table around, 1 in 3 emergency department visits are potentially avoidable among seniors who live in long-term care facilities. So do they need to be going to an ER in the first place? Is there different ways that we could address that? So I think that, I'm not sure if I've actually said that, but advocacy, I think, is the biggest piece going forward around this. Once we do have some insight around, who should frailty screening be applied to, what tools, those kinds of things. But probably John has more to add to this. He's been in this area much longer than I have.
So thank you. So I think that the recognition is not aging in itself is not a big cost driver, but we have to look at where the cost drivers are. So for example, 40% of all healthcare costs are spent in people over the age of 65, 20% in the last year of life, and then when you actually start to look at that, and the intensification of care at the end of life is maybe one area where there's a lot of opportunity, where intensification of care, which can be quite costly, does not actually lead to improved outcomes. So you have the situation where you have more expensive care, more intensification of care, but with poor outcomes or worse outcomes. So by improving care in a holistic type of manner, especially towards in late life, we have the situation where we can improve care, improve quality of life, but at a reduced cost. So I think that that's one opportunity. And then when you look at chronic disease management, I think one of the things that chronic disease management is extremely important. But what we have to get away from the single disease type of management strategy. So you manage your heart failure by one specialist, you manage your kidney failure by another specialist, your diabetes by somebody else, and so on and so forth. And although that's okay, I think that's the concept of moving towards frailty, where we can actually look at a holistic models of care, where we actually look at the totality of the person, and I think that's where our focus is should be. And not to denigrate or the single disease management, but I think we need to shift over to a holistic models of care and show that that's an important, that it's what Canadians want, or what elderly people who are frail want, and I think that's where we can be more responsive, and I think the Canadian healthcare system will lead to better outcomes at potential reduced costs.
Thanks very much, both Kelly and John. I'm going to read an important comment that came from one of our participants. He writes that mammography was mentioned, but there has been somewhat of a pullback on cancer screening in more recent consensus guidelines. For example, mammography, PSA testing, colonoscopy. And he's suggesting that we will have to demonstrate the effectiveness of frailty screening to withstand scrutiny with good evidence. So thank you very much for that comment. The next question I have to John, it relates to patient engagement. Now, as Kelly discussed, patient and family perspectives and involvement are essential. Related to this, I just want to let participants know that HealthCareCAN has just developed a new online program with respect to patient and family-centered care and engagement strategies and putting them into practice. We'll be sending out some information about this course, this online program, after the webinar, in case there are participants who would find this of interest. So John, our specific question today is, what efforts are being taken to ensure patient and family engagement?
Thank you. So I think that is, and that's there's increasing recognition of the importance of patient and family engagement in all aspects of healthcare. But the people who are frail and their caregivers have very specific, there's very specific needs, and also there's barriers to engaging with this population. And towards this end, that's been a big, so there's been two separate knowledge mobilization foci of our network. One is on the recognition of frailty, but the other one is on looking at how we can actually engage patients who are frail, or people who are frail, and their caregivers. So towards that end, we held a forum last September, where we invited citizens, citizens who were frail, their caregivers, clinicians, researchers, policymakers, and decision makers together to articulate what that could look like. There's been a discussion paper developed in that, specifically outlining the how that can be done, and the barriers and enablers that can be put in, or the enablers and potential to overcome barriers, and how what those look like, and it should be published shortly, and then we will actually do a whole-scale public engagement based on that document. In the Canadian Frailty Network, we have citizens on every one of our committees, and we have a citizen engagement committee to be sure that we address some of the issues of frailty. And I think people who are frail and their caregivers need to be involved in the three aspects of the healthcare system. The first one is in setting the research priorities, and we're actually have an initiative looking at setting and seeing what research priorities are important to people who are frail and their caregivers. The second is to be involved in running of the healthcare system and have input into that, because there's issues that have been identified, and I think if we had input right from people who are frail, their caregivers, those issues may be better. And the third one is in actually be involved in policy setting to sort of drive some of these things forward. So as a network, we're going to be advocating involvement in all those areas.
Thanks so much, John. We've received many, many questions and comments, so very grateful for the level of interest and participation, and we'll be sure to incorporate all the comments that were raised into our paper and these questions. I have a final question I'm going to turn over to Bill. So the question we received in advance of the webinar, it was, should we consider screening pre-frail seniors to see if we are able to prevent and delay frailty? Bill.
Well, again, that's a tricky question. I'll go back to Kelly's comment. We learned a long time ago that an ounce of prevention is worth a pound of cure. The problem here is universal screening for those that are maybe asymptomatic or aren't at risk or at high risk would cost a ton. So again, this comes back to that earlier question about the cost effectiveness of screening, and obviously you'd have to try and strike the right balance there in terms of a more focused approach to screening that's reasonable from a cost point of view.
Okay, all right. Thank you so much, Bill. I want to thank all of our participants today. We were delighted with the level of participation today for our webinar and level of interest. Once again, I want to thank John Muscadera, Bill Thal, and Kelly Grimes for taking the time to present this webinar. As I mentioned at the outset, today we presented some preliminary results from our research. If you have any comments or suggestions to inform our research, things you want to make sure we keep in mind, questions we haven't answered, we would like to hear from you. Please send any comments or questions to me, Jennifer Kitts, jkitts@healthcarecan.ca. And as I mentioned, we'll be sending the PowerPoint and the recording to you under an email later following this webinar. We'd also like to hear from you about this webinar, so we'd appreciate it if you could take some few minutes right now, if possible, to complete the evaluation. You can click the link on the screen now. Finally, I want to let you know that HealthcareCAN will be hosting regular health policy webinars. Our next webinar will be taking place at the end of June, early July, and it's going to focus on the Health Accord. We heard a lot about the Health Accord today, and we think it's timely that we host a webinar on the Health Accord. And specifically, we're going to present on what some of Canada's health leaders would suggest be included in the next multi-year Health Accord. So we'll be keeping you posted about this upcoming webinar and other web policy webinars, and we'll provide you with a confirmed date when it's available. So thanks again to everyone for attending this webinar. We hope that you found it informative. I know that I certainly did, and I know that this discussion, this presentation will be, and the discussion and comments will be very informative to us as we complete our paper, and we wish you a pleasant afternoon. Thank you.